Good day to everyone joining us and welcome to today's X-Talks webinar. Today's talk is entitled Fecal Matters, Clinician and Laboratorian Perspective on Impact of Molecular GI Pathogen Testing. My name is Sarah and I'll be your X-Talks host for today. Today's webinar will run for approximately 60 minutes and this presentation includes a Q&A session with our speakers. This webinar is designed to be interactive and webinars work best when you're involved, so please feel free to submit questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. This chat box is located in the control panel on the right-hand side of your screen. If you require any assistance, please contact me at any time by sending a message using this chat panel. At this time, all participants are in listen-only mode, and please note that this event will be recorded and made available for future download. Live audience members can apply to receive a professional acknowledgement for continuing education or PACE credit issued by the American Society for Clinical Laboratory Science through our exit survey at the end of today's session. Certificates for approved applications will be emailed by June 9th. At this point, I'd like to thank Luminex, who helped develop the content for this presentation. Luminex's mission is to empower labs to obtain reliable, timely, and actionable answers, ultimately advancing health. They offer a wide range of solutions applicable in diverse markets, including clinical diagnostics, pharmaceutical drug discovery, biomedical research, genomic and proteomic research, and food safety. They accelerate reliable answers while simplifying complexity and deliver certainty with a seamless experience. And now I'd like to introduce our speakers for today's event. Dr. Lopansri received his Doctor of Medicine from Loyola University in Chicago in 1997. He completed his residency at Loyola University of Chicago in internal medicine from 1997 to 2000 and a fellowship in infectious disease from the University of Utah Medical Center in Salt Lake City, Utah from 2000 to 2003. Since 2012, he consults on the inpatient clinical service at Intermountain Medical Center and LDS Hospital, serves as medical director of the Intermountain Central Microbiology Lab, and is an associate professor of medicine at the University of Utah. Dr. McNabb performed his doctoral work in initiation of immune response, autoimmune disease, and vaccine development at the University of South Carolina School of Medicine and earned his degree in 1999. Dr. McNabb has been the Director of Microbiology, Immunology, and Molecular Testing at New Hanover Regional Medical Center since June of 2012. So without further ado, I'd like to pass control over to today's first speaker. And Dr. Lopansri, you may start your presentation whenever you're ready.
Okay. Great. Thank you very much, Sarah. Can you see my screen okay?
We can, yes.
Okay. Good afternoon. I'd like to start by thanking Luminex for the invitation to participate in this webinar, and to all of you for taking time out of your busy schedules to attend. So I'm going to skip there, and just to give you a little bit of background about where I currently work, Intermountain Healthcare is an integrated healthcare network that operates 21 hospitals in Utah and one in southern Idaho. Intermountain also has 185 affiliated clinics and urgent care centers. Microbiology support is provided by 6 Intermountain laboratories, 5 are regional laboratories supporting 6 hospitals, and there's a large central lab providing routine micro and molecular services to 16 facilities. I currently serve as the medical director at the central laboratory, and I've been fortunate to have assumed this role at a time when there's been this explosion of novel and innovative diagnostic technologies. So what I'd like to do with my time today is to go back to the basics. I've been asked to discuss how clinicians approach patients presenting with acute diarrhea. So I'd like to share with you some of my experiences and how we're attempting to integrate some of these innovative technologies into our laboratory and clinical workflow. I'd like to start with a series of clinical vignettes. The first one is a patient who presented with unintentional weight loss that started after a colonoscopy. So she underwent a colonoscopy, and the following day she felt unwell with malaise. That evening she developed severe, profuse, watery diarrhea that persisted. She denied fever, chills, abdominal cramping, nausea, or vomiting. She was brought to the emergency room and admitted to the ICU following a syncopal episode, and she was found to be severely dehydrated with acidosis, acute oliguric renal failure. She was started on hemodialysis and was aggressively rehydrated. And she had about 10 liters of diarrheal output a day in the first 3 days. She had no no exposures, and on exam she was afebrile, appeared acutely ill, had dry mucous membranes, and was dehydrated. She was in renal failure, as mentioned. Her white count was 23,000. So with respect to vignette 2, this was a 28-year-old otherwise healthy woman who was admitted with abrupt onset of fevers, rigors, headache, nausea, vomiting, and diarrhea. The diarrhea was watery and initially was described to not contain any blood or mucus. The diarrhea was associated with abdominal pain. 1 day earlier, she had attended a reception at a local restaurant. On exam, she was febrile up to 40.1, tachycardic. She was uncomfortable appearing with diffuse abdominal tenderness and no peritoneal signs. Her white count was slightly elevated with 18% bands, and the stool lactoferrin was positive. The chemistry panel and the LFTs were otherwise in normal limits, and a CT scan of the abdomen revealed diffuse colitis. Vignette 3 is an outbreak in travelers. The first patient was a 40-year-old otherwise healthy man who developed abrupt onset of vomiting of about 3 episodes and malaise while traveling in Tokyo. The following day, patient felt fatigued with malaise and had 3 loose stools, and about 24 hours later he returned back to the baseline. The second case was a 13-year-old boy who was the son of patient A, who was brought to the ER in Bangkok for an abrupt onset of vomiting of approximately 5 episodes. In the ER, he was thought to have poisoning from herbal medicines, as he was given some herbal mushrooms a few hours before he developed these symptoms. So he's treated with activated charcoal and given an oral cephalosporin, which he didn't take. And about 48 hours after onset of illness, he returned to normal. The third patient was a 14-year-old boy who was a cousin of the second patient, who developed abrupt onset of vomiting followed by diarrhea, malaise, fatigue, and low-grade fevers. Again, his illness resolved within 2 days. In total, 4 additional members of the travel group became ill with a similar illness. The last vignette is a 20-year-old man who was admitted to the hospital for a peripheral blood stem cell transplant. On post-transplant day 2, he developed fever and diarrhea, and this was hospital day 5, so a broad GI pathogen molecular panel was obtained and was negative. The diarrhea continued to worsen with abdominal cramping, tenesmus, and approximately 10 to 16 episodes of small volume stools per day. On post-transplant day 22, continued to have fever and profound diarrhea, so a GI panel was repeated. I'll get back to those vignettes a bit later. Diarrhea, gastroenteritis is an extremely common cause of morbidity and mortality globally. It's estimated that 1.7 billion cases of childhood diarrhea occur globally each year, and it's a leading cause of malnutrition and the second leading cause of death in children under 5. In the U.S., it's estimated that approximately 179 million cases of acute gastroenteritis occur annually. Of these, about up to almost 10 million are associated with foodborne illnesses caused by 31 pathogens. These foodborne illnesses contribute to almost 56,000 hospitalizations and over 1,300 deaths per year. The majority of these illnesses are attributed to viruses, with norovirus being the most common cause. And bacteria are the second most common cause of foodborne illness, and parasites are relatively infrequent. With respect to foodborne illness from unspecified agents, it's actually estimated that this is correct, but it should be 38.4 million cases of acute gastroenteritis are attributed to unspecified agents. So, with respect to the causes of foodborne diarrhea since the implementation of these culture-independent diagnostic tests, I'd like to highlight a recent publication in the MMWR by the CDC, which many of you may have already seen. This publication describes the incidence and trends of infections from foodborne pathogens with increasing use of culture-independent diagnostic tests. What they show is increase in infections from all of the major pathogens, particularly Campylobacter, Salmonella, Shigella, and increase in the Shiga toxin-producing E. coli. However, the increase is not severe, not as great as the other pathogens. Culture negative and uncultured cases shown here in the lighter blue colors were far greater than the culture-confirmed cases. What was interesting to me was the marked increases observed in Vibrio and Yersinia infections, many of which were not culture-confirmed or not cultured at all. So since these culture-independent diagnostic tests have been implemented, aside from culture-confirmed Campylobacter, there has been an increase in the incidence of the major pathogens causing gastroenteritis. So how do we approach a patient with acute diarrhea? Well, the first step is really to confirm the presence of diarrhea. It's amazing how sometimes when diarrhea is mentioned, there's a couple of questions brought up, and then it just often not fully characterized. So diarrhea is commonly defined as the presence of 3 or more unformed stools in a 24-hour period. Infectious cause of diarrhea requires the presence of other symptoms, enteric symptoms, such as nausea, vomiting, abdominal pains, tenesmus, fecal urgency, and moderate to mild flatulence, moderate to severe flatulence as some of the other associated symptoms. Characterizing the severity of illness is also and hydration status is also critical, and is broken down to total severe diarrhea, which is total disability due to the diarrhea, as illustrated in Vignette 1. Moderate diarrhea is patient is able to function, but with forced change in activities due to the illness, as in Vignettes 2 and 3. And a mild diarrhea, which doesn't impair any of the activities. Categorizing illness as acute, which is less than 14 days, persistent, which is 14 to 30 days, and chronic is also helpful for the clinician to gauge and assemble a potential list of pathogens. A detailed history with an emphasis on the symptom complex and epidemiologic exposure is also critical to help determine the mechanism and potential pathogens causing the diarrhea. Here's some of the common critical pieces of information that we like to gather in the clinical arena: food consumption, travel history, epidemiologic exposures, exposures to sick household contacts, the time of year at which the diarrhea developed, any new medications or antibiotics characterizing the diarrhea, as I mentioned earlier, and the presence and absence of systemic symptoms. And again, the vital signs and volume status are critical. Breaking the illness down to site of acquisition is also important and can be helpful in determining a list of possible pathogens. And generally, it's broken down to, we break it down to community-acquired or traveler's diarrhea, hospital onset diarrhea, which the most common pathogens are Clostridium difficile and norovirus, and chronic diarrhea, which often is not an infectious etiology, or persistent diarrhea. And these are some of the sample pathogens that are commonly implicated in with persistent diarrhea. With respect to community acquired gastroenteritis, we break it down further to diarrhea associated with systemic symptoms or bloody diarrhea, watery diarrhea, which again characterizing it as either severe profuse purging or mild to moderate non-inflammatory diarrhea. And some of the common pathogens implicated in diarrhea or dysentery or diarrhea with fever and bloody stools are Salmonella, Shigella, Campylobacter, Shiga-toxin-producing E. coli, Clostridium difficile, and Entamoeba histolytica. With watery diarrhea associated with severe profuse purging, Vibrio cholera and enterotoxigenic E. coli are some of the common pathogens. And with mild to moderate non-inflammatory diarrhea, we talking about some of the viral causes such as norovirus, rotavirus, and sapovirus. And norovirus, some of the classic characteristic presentation includes prominent vomiting early in the course of disease, as illustrated in Vignette 3. So a quick word about therapy. The mainstay of therapy is rehydration. Antibiotics may or may not be indicated in acute gastroenteritis, and it's been shown to be beneficial in moderate to severe cases of Shigella, enteroinvasive E. coli, enterotoxigenic E. coli, Vibrio, cholera, Eromonas, and Plesiomonas. Antibiotics are also beneficial in severe or prolonged cases of Campylobacter. However, antibiotics may not be indicated in most cases of Salmonella and may prolong shedding, and antibiotic use can be harmful in Shiga toxin producing E. coli. So I'm going to shift gears to talk a little bit about who should undergo diagnostic testing for acute gastroenteritis. And testing is challenging, and as it's important to try to achieve the right balance of who to test and who not to test. Delaying diagnosis or under testing has antimicrobial stewardship implications, as this can contribute to over-reliance on empiric or inappropriate antibiotic use that may be unnecessary or could be potentially harmful. For example, use of a fluoroquinolone in a patient with bloody diarrhea may not be wise given the possibility of Shiga toxin producing E. coli. Delayed testing can also have infection control implications, especially with norovirus and Clostridium difficile, as this could lead to secondary transmission if infection control measures were not initiated originally. Delayed testing also has public health implications, as it can impede or delay disease surveillance and outbreak detection. Overtesting similarly has problems as well. Overdiagnosis can lead to unnecessary antibiotic use. For example, a patient who has mild diarrhea from Campylobacter may not necessarily need an antibiotic treatment. Overtesting can also impact patient management, especially if there is an unexpected result. When the detected target is not consistent with the clinical syndrome. Finally, public health implications are important for overdiagnosing, especially with use of molecular tests, as some of the reasons cited for that is not having the isolates available for antibiotic susceptibility testing or for outbreak investigation. And finally, cost implications are important here. Recently I had a clinician evaluating a patient with acute diarrhea in the outpatient setting, and she had ordered numerous singleplex tests, and she had mentioned that the reason she didn't order the panel was because of the cost. But she had to order about 4 or 5 different tests in order to evaluate this patient with diarrhea. So a pretty solid and good recommendation that I've come across about how to think about and approach diagnostic testing with severe diarrhea was published by Bert in the New England Journal of Medicine, and he had suggested to reserve testing for patients at high risk for diagnosable diarrhea or cases in which identification of a pathogen would be important. And diagnostic testing was recommended for cases of acute diarrhea that's severe or associated with fever, persistent diarrhea, profuse cholera-like watery diarrhea, diarrhea associated with that led to dehydration or has dysentery, in immunocompromised patients, food handlers, daycare workers, nursing home residents, and disease associated with outbreaks were also recommended as being situations in which diagnostic testing is recommended. The American College of Gastroenterology recommends use of diagnostic tests in the setting of dysentery with mild to moderate to severe disease, and for cases in which symptoms last for more than 7 days. And these are strong recommendations, and they note a very low level of evidence. They also touch upon use of the culture-independent tests and recommend that these be used if available or at least be used as an adjunct to traditional methods. Again, this is a strong recommendation with a low level of evidence. They mentioned about antibiotic susceptibility testing for the management of the individual that is not recommended. I'm not quite sure if I fully agree with that in light of the Shigella, the antibiotic-resistant shigellosis and Campylobacter emerging these days. The Infectious Disease Society guidelines are being updated as we speak. So in the central lab, these are the some of the conventional singleplex tests that we offer to our clinicians: the stool culture, norovirus, PCR, rotavirus, antigen detection, C. diff. We use the algorithmic approach with GDH and toxin, followed up by PCR for discordance. We offer Shiga toxin detection and also cultures for 0157. We use the combined Giardia cryptosporidium antigen testing, and we do microscopy for ova and parasites as well. However, we encourage these tests to be ordered only when there is a travel history. Now, this is a summary table of the approved culture-independent tests. And we were interested in the BioFire film array GI panel and the VERIGENE EP panel, as we had these systems in place for other reasons already. And this is the configuration of the film array panel, and this is the configuration of the VERIGENE enteric pathogens test. And what intrigued me about these tests was that these were configured differently in a way that could be taken advantage of for different patient populations. So it offered us the flexibility to meet the different types of patients that we encounter in the clinical arena. And this is how we encourage clinicians to approach patients who present with acute diarrhea. As always, the road to diagnosis starts with a detailed history, and with moderate to severe disease, or to cases in which there are public health implications, infection control implications, we recommend testing be ordered. If the history and physical exam leads to a fair degree of certainty as to what is causing the diarrhea, we recommend targeted testing based on the epidemiologic exposures, the diarrheal pattern. However, if there are a degree of diagnostic uncertainties, or if several tests were to be ordered, more than 2 tests in particular, we recommend use of the culture independent test. We also recommend use of these culture independent tests if immediate management depends on a fast answer. With these tests, we ask clinicians to consider whether or not the illness is associated with recent international travel, or if it is occurring in an immunocompromised host. If not, we encourage use of the VERIGENE enteric panels, enteric pathogens test, plus alternate other tests as indicated, as this will identify all the common pathogens encountered in the U.S. With a travel history or in patients who are immunocompromised, we recommend use of the broader panel, as they include some of the pathogens more commonly seen in the international setting. So back to our vignettes. The first case was, well, I'd summarize it as profuse purging. The fecal WC was, actually that was a fecal lactoferrin was negative. At that time we were evaluating the EP test, and for some reason the clinicians didn't order a stool culture on admission. The EP test was positive for Vibrio cholera, which surprised us all quite a bit because of the absent epidemiologic or exposure and no travel essentially. With that result, we went and set up a stool culture which was positive for Vibrio cholera, the albensis. She was aggressively fluid rehydrated, replaced, as I mentioned, and with the result of the molecular test, we started the patient on doxycycline, and 24 hours later, the volume of stool decreased dramatically, almost by half. The second vignette was summarized as I'd summarize as an inflammatory and invasive gastroenteritis. The fecal lactoferrin was positive, and this was right around the same time we were evaluating the two molecular panels. Both of them were positive for Shigella species. The culture, which was ordered on admission, was negative, and we attempted to cultivate that isolate another time and was unable to identify Shigella. But because the targets match well with the clinical syndrome, we concluded that was a true positive. I should mention also that this case was, with this case, there were 14 other attendees of the reception that were ill with similar disease, but none were severe enough to lead to hospitalization. This patient was rehydrated, treated with ciprofloxacin, and did well and was discharged. The third vignette, the cluster, this was norovirus. We kept everyone out of the hospital, hydrated them, administered an enormous amount of sympathy, and again, just kept them away from any emergency rooms abroad. The last vignette, this was a hospital onset severe diarrhea post stem cell transplant. One molecular test was positive for Vibrio cholera. The second was negative. The stool culture was negative. Now, had I not been involved with the first vignette, I would have said there was 100% certainty that this was not Vibrio. With this result, I was 99.5% certain that this was not Vibrio. But it didn't matter. It was positive. The patient was rehydrated, and diarrhea actually started to improve when certain medications and tube feeds were adjusted. But he received doxycycline anyway and continued to slowly improve. So with that, I'd like to conclude by saying that while there may be clinical overlap in many cases, a detailed history and physical exam is still the cornerstone of diagnosis and can help guide the workup of a patient with acute gastroenteritis. The molecular panels have an important role and can help improve patient care, but it still does not replace clinical judgment. And clinical Vignette 4 was one of those that really made us think, and we had a lot of detailed conversations about it. But at the end of the day, the decision was made to treat anyway. The molecular panels can create a great deal of confusion when an unsuspected pathogen is detected and does not explain the clinical condition. But in the end, I think these technologies are extremely exciting and have a great potential to improve how we approach patients with acute gastroenteritis. But still, clinical data about the impact of these panels are desperately needed. With that, I will conclude, and I will pass the ball over to Dr. McNabb.
All right. Thank you, Dr. Lopansri. That was very interesting, and our experience here with clinical has been very, very similar. Thank you all for listening today, and today I will be discussing our experience with implementing a molecular enteric panel at our hospital. Here, we're a New Hanover Regional Medical Center, and our healthcare system is a 700-bed community hospital system that includes level 1 trauma center. We cover approximately 120 miles of the coast from Myrtle Beach to Jacksonville here in North Carolina, and we also include Pender Memorial Hospital and Cape Fear Orthopedic Hospital in our group, as well as a urgent care external emergency department on the other side of Wilmington. And of course, we do have a large pediatric and women's and children's center here, along with Zimmer Cancer Center. So while we're not nearly as large as Dr. Lopansri's folks, but we're for North Carolina, we're considered fairly large. And traditional stool culture, as most of you listening probably already know, requires that you collect the stool. You're going to plate the specimen, incubate it for 24 to 48 hours, and then you're going to look at these plates and try to isolate possible pathogens. And then when you see possible pathogens, you'll then identify them through some mechanism. And that was how we did it here for years and years and years, and it is a very good system. It will isolate pathogens from stools, but we felt like, with emerging technology that we wanted to go a different direction. And of course, the problems with stool culture, as most everyone will know, is you require specialized media. Their technologists have to have experience to read these plates. So if you have newer technologists, it's a train up to actually do that. And some organisms require specialized environments, such as Campylobacter, which is microaerophilic. And you also get multiple specimens from the same patients. And here at our facility, we've seen physicians go 1, 2, 3, or more specimens for one patient with diarrhea. That's an inpatient. And here at New Hanover, we actually had a technologist half a day, 7 days a week, just to do stool culture workups. And our recovery rate tended to be low, I thought, at 10% for bacteria. And our turnaround time tended to vary from 3 to 4 days overall. And our culture is, of course, limited to just bacterial pathogens. So if you suspected viruses or something else, you had to do some additional testing. And the ship-out panel through our reference lab here for a full viral panel for enteric pathogens is around $500, which we felt was excessively expensive. To start talking about molecular testing here, I was required to start talking to our management staff. And I went to them and said, well, we think it's going to reduce our materials. We'll get rid of all these additional culture plates. We did think that it would save space ultimately for us. We could get rid of specialized incubators for some of these pathogens. For Shiga toxin producing E. coli, we were not doing them all patients that came in. We were looking for blood in the stool, testing for blood in the stool, then reflexing. The physicians were having to order that special if they suspected that. We did think that it was going to reduce overall technologist time per specimen, and of course molecular has a much better sensitivity than culture, and we'll really look at that in a little bit later. Of course, the cons, you do have to have reagents. Some reagents for some of these systems require a refrigerator, some are room temperature, and then some also need freezer space, which is a concern, and it's always tight in a laboratory. And the biggest concern from the management team, of course, is that molecular tends to be more expensive than routine culture, and the initial cost to your facility seems kind of high. So when I went to do this initial presentation, this was in 2014, towards the end of 2014, they asked me to do a cost assessment, and this was my cost assessment. This was 2,300 cultures in the year, and we looked at how much we were spending for plates and how much technologist time was invested in the cost of the technologist compared to bringing in a molecular test. And we actually picked the least expensive of the platforms at that time, and then we looked at, what we thought the volumes were going to be with some repeat testing. And you can see there it's $100,000 cost for us per year to do 2,300 cultures, and to do similar workload with the molecular was $159,000, which you look at that and go, it's, well, $60,000 more. That doesn't seem too bad. Of course, our managers immediately asked me not to include labor expense because we're not going to get rid of any personnel. So when you look at it from that perspective, it looked like it was going to be around $100,000 more expensive to do molecular testing compared to culture. So after I showed them that, I went back and showed them that, it did not look good for us implementing molecular testing here. So I went back and talked about additional benefits of molecular. We were doing a separate rotavirus test here in the laboratory that was a manual test. We were getting them not on all cultures, stool cultures, but we were getting them on most of the stool cultures. And a lot of clinicians were ordering a ship-out norovirus test. And the interesting thing was most physicians were ordering norovirus since it's fairly common, but then some clinicians were ordering a norovirus and then reflexing and trying to order a full viral panel for enteric pathogens, which was quite expensive. We felt like that with molecular and our other molecular testing, the technologist would touch it once and be done. And then all patients would get Shiga toxin testing since all of these molecular platforms offered that. And of course, improved specificity and sensitivity, and no more ruling in and out Salmonella, Shigella. And the biggest thing was we wanted the same test for all patients, and we wanted to get more rapid results. So the FDA approved systems at the time we were looking were Nanosphere, BioFire, Luminex, and BD Max. Of course, as been mentioned, most facilities want to look at systems where you already have the equipment, and that was the case with us. We looked at the BioFire. We had a system here that we were running Ebola testing on, and we showed these panels to our clinical staff, ID physicians, emergency department physicians, managers, and said this is a panel that we could offer. Most of the discussions and all of these presentations revolved around, could they order part of the panel, not part of the panel, were they going to have to get all markers? A lot of clinicians, older clinicians especially, thought it was kind of big, and they didn't want to charge their patients for this. And then the other, some clinicians here felt like they didn't really need that big of a panel. And for the managers, the biggest pushback was on the price. And for the lowest price to this, it can be double to triple the cost of the lowest platform we were looking at. And ultimately, we selected the VERIGENE enteric pathogens panel for our facility. The ID physicians and our pediatric folks felt like this matched what we were doing with our stool culture. We were mostly looking Salmonella, Shigella, Yersinia, and Campylobacter, and it did offer the more common viral pathogens, and we felt like we could eliminate our manual rotavirus test. The biggest pushback on clinical staff really was that this test did not speciate Salmonella and Shigella, Vibrio, and they were not as happy with that. But after everything was said and done, between the cost was more acceptable and the clinicians felt like they could live with this panel and if we removed stool culture. Of course, we did what all good labs do. We did a validation study comparing stool culture to the VERIGENE. During that time, we did note that there was the VERIGENE would pick up things that we were not picking up in some cultures. We trained all of our personnel, of course, 20-day QC, and the biggest thing was to work with IT on interfacing the system and also working with our clinical staff to make sure they were informed of the change and what markers were available, and that this was a molecular test. And we discussed a lot with them the sensitivity and specificity of this test, because we felt like that was a big selling point, and we wanted them to understand what they were actually getting when they ordered it. And we ultimately decided that when you ordered this, you would get all the markers on the panel. Because this panel was small enough, we felt that that was not excessive. We do receive the specimens in the lab. We do receive some in Carrie Blair. 90% of our specimens come in in a cup as a fresh specimen off of our floors. And the enteric panel, VERIGENE enteric panel, does require that the stool be in Carrie Blair, or you would have to do a validation or verification study of your own to validate direct specimen, and that was not something that we ultimately decided we wanted to do. So what we ended up doing was making Carrie Blair here in our laboratory, and we make it about every 3 months, and once we do that, we can dispense it into vials. And it's about a nickel a specimen, which was substantially cheaper. And of course, the enteric panel workflow for us, it worked well with our staffing. The specimen comes in, you put it in Carrie Blair, then you mix it well, then you add it to the buffer for the VERIGENE, you vortex it, then spin it down, then it goes on the system, and you get results. You either get a negative result, it's tested and finalized, or you get a positive result. And in the 2015, when we implemented this test, we actually did confirmatory culture, ID, and sensitivity on all positive bacterial cultures for the year, because the doctors wanted to know if it was negative, what was the chance that it was really positive, and we wanted to sort of collect that data for them. And then we also were asked to look at additional testing, C. difficile testing, ova and parasite screen, and WBC for stool, to see if running this panel had any impact on that type of testing as well. And the way we reported it was negative for all markers, and we did put a comment in that the physicians could see. And this test, our test, does not do Aeromonas and Plesiomonas or parasites. And then, of course, if it was detected, which was about 15% of our testing, we would tell them it's detected and the analyte detected, and then we were doing follow-up. We did send all of our Shiga toxin 1 or 2 positives out to the state to confirm toxin, and I'll show you a bit of those results as well. And this is what was on the panel, and then it's a little small to read. I know it's a little hard to read, but we do have comments that we did put on all of these results. So if it was CAMPI positive, there would be a comment on there that the physician can see. We've been running it over 2 years now, so physicians are very familiar with these. Now, some of our outcomes. So in the first year that we ran this testing, at the end of the year, we went back and looked at our average cost for stool culture. It was costing us around $44 a culture, and our reimbursement was $59. And we don't really use reimbursement here as any kind of a deciding factor, but I included it on this slide so you can get a feel for what the average reimbursement for our patients, for our laboratory from our patient population. The interesting thing that I found is that we had estimated it was going to be $160,000. Our actual cost was around $89,000. And if you remember back to the slide on costing, it was costing us $55,000 just to buy the reagents and the ancillary testing costs. So it's really, the test was not nearly as expensive as we had anticipated, and actually it only cost us around $30,000 more than simply buying the plates and the other things required for regular stool culture. So the management team here was quite pleased with that result. Our turnaround times went from, of course, days to hours. Our average turnaround time in the second year actually went down to 3 hours and 8 minutes, and our positivity rate both for 2 years has been 83% of them are not detected, 13% are bacterial pathogens, and compared to what we were getting with culture, which was 6%, so we actually more than doubled what we were detecting with culture by going to a molecular methodology. And of course, the viral pathogens were 4%, but the nice thing is we're no longer shipping them out. And then when you look at the culture follow-up, what we found was Campylobacter grew out 70% of the time, roughly. We expected that. Salmonella would be recovered 87% of the time. And we didn't have that much Vibrio, but we were able to recover it 2 out of the 3 times. And almost 90% of the time, Shigella positives would grow. So we felt comfortable that this test was picking up what we would pick up in culture, but we certainly believe that we're able to pick up, at least the sensitivity was better with our molecular panel. And then we looked at, this is our other testing, to see if other testing went down with this molecular panel. And you can see in 2014 with stool culture, what the rates were. 96% of the time they were ordering C. diff. And as you can look, as we progressed 2015 and 2016, C. difficile went down slightly and has really maintained. Parasite testing went down substantially, and it actually still continues to go down. So once they run a C. diff and an enteric panel, we found the longer we ran the test, the less clinicians were looking at parasites as a cause. And then, of course, stool WBC went down slightly, but it really didn't go down that much. They still order quite a few of those. The real impact we thought, especially in our first year, and that has continued into the second year of testing, was our admission rate for diarrheal cases was about 67%, and that was women's and children's and our emergency departments. And after we initiated the enteric panel, our admission rate now averages about 35 to 38% of those screened with diarrhea and an enteric panel are getting admitted. So we reduced how many patients actually had to be in the hospital, and for us that's significant because our hospital does get full quite often. And then, of course, length of stay, and we looked at all patients that had an enteric panel done if they were admitted, and generally speaking, the length of stay for all these patients went down compared to routine culture. And we were quite pleased with that because a one-day reduction at our facility can save the patient anywhere from $5,000 to $15,000. And when we first started doing our validation study on the VERIGENE, what we found was that I randomly picked 10 stool cultures that came in, and they were from the emergency department, and we ran them, and 5 out of the first 10 were positive for norovirus. So the technicians, technologists called me in my office and said they thought there was something wrong with the testing, so we actually went into the lab to check the results. I called down to the ED, and it turned out that 2 of the patients were from the same elder care facility here in Wilmington, and 3 of the patients were from another, a different elder care facility out of the patients that had been seen in the ED. And then in the next 15, we found 5 more positive for norovirus, and those 5 were from one of those 2 facilities. So by Friday afternoon, this was late Friday because everything happens in a lab late on Friday, and I talked to the medical director, and he said we're going to inform the ED of the results even though we hadn't gone live yet, and we sent all of the specimens out for confirmatory norovirus testing. But we felt like if it was norovirus in an elder care facility that we wanted them to be aware of it. We did notify the public health nurse here in our hospital who talked to public health, and by Saturday around 11 o'clock they had quarantined both of the elder care facilities and started contact precautions. And I got a call Saturday from the public health lab in Raleigh to ask what we were doing because this was the fastest they had detected an outbreak of norovirus, and we were quite pleased with that. And then the very first case we had after we went live here, it was a Sunday about 1 in the morning. They had a 12-year-old boy in our emergency department. He came in with very severe diarrhea. They ordered a C. diff and an enteric panel. They started hydrating the patient as well. And when the test came back, it was positive. The C. diff was negative. The salmonella positive on the enteric panel. And by 4 o'clock in the morning, a couple hours after they had arrived there, the parents were advised that the son had responded very well to hydration, and they felt like the patient didn't need to be in the hospital. They did order a home check on Sunday, so that they called and checked, and then on Sunday said the boy was doing much, much better, and then the next few days it resolved entirely. So what we have decided based on our experience is that we've continued to use molecular testing for rather than stool cultures. The actual cost is far less than we initially anticipated, and that's mostly because we're not really letting the providers do multiple tests. They get one molecular test. In certain cases, we will do that as a case-by-case basis, but we try to discourage that as much as we can. O&Ps continue to drop. It's very low, as such that we stopped actually offering them in-house. We are looking for a molecular solution for that down the road. One of the things we did learn is you got to have a lot of coordination with your physician staff, infection control, and pharmacy before you go live with this kind of testing. They really need to understand exactly what this test is telling them, and we continue that education. And I think the biggest downside for us has been that North Carolina requires Salmonella, Shigella, and Yersinia. They like them to be sent to the state, and they don't have the staff to isolate them. We still do culture and sensitivities on those isolates anyway, mostly for pediatric cases, but they do want them isolated and sent to the state lab. So we are still doing not patient culture per se, but culture to isolate the organism for ID and ASTs, and also to send to the state lab. And of course, I do not do any of this stuff in my laboratory by myself, and this is our staff. And as you can see, for a 700-bed facility with all of our outreach facilities, this is my entire microbiology staff, and does not include our manager, Kevin Briggs, our administrator, and of course Dr. McKinney, our medical director. And with that, I would be willing to take any questions.
Great. Well, thank you very much to both of today's speakers for those insightful presentations. I'd like to invite our audience members to continue sending in their questions or comments using the questions window for the Q&A portion of the webinar, and have already received a few questions, so let's go ahead and get started with those. The first question, are there any initiatives from state health departments to require reporting of molecular test results in order to aid in surveillance efforts?
Well, I can tell you that we report all of the positives. It gets reported to our public health lab and our state lab here, and then we do send Salmonella, Shigella, and Yersinia to our state lab for their program here. So we are actually reporting those already.
Our experience here in Utah is the same. We report the positives to the state, and we also submit isolates to the state public health lab. And with the positive culture independent tests, we send the stool sample to the lab as well if we're unable to cultivate the isolates. For ETEC or 0157, we go ahead and just submit the samples to the state health lab.
Great. Thank you both for weighing in on that question. Our next question, what is your policy for repeat testing or test for cure?
We only allow repeat testing on C. diff or in our enteric panel every 7 days, so it's got to be 7 days or more between tests. We generally don't like them to do that, and our test cannot be used as a test of cure.
For over here, that's the same way for us with respect to C. diff testing. We restrict it to one test over a 7-day period, no test of cure, and we cancel formed stools. With respect to the culture independent test, that's been a pretty big challenge. We want to encourage clinicians only to order one and to limit its tests at least to every 7 days, but sometimes that proves to be challenging. So we are actively working to understand how these tests are being used, but I think the ultimate goal is to try to restrict the number of times these tests are ordered during an encounter for a particular illness.
All right, great. Another question here. Have you received any pushback for not culturing Aeromonas or Plesiomonas?
Yes, and here in North Carolina, that has been a pathogen that we do see. The way we did it in the past was we asked the clinician if they were concerned about that they needed to let us know when they placed the order, and we have a comment field that will pop up and look for Ehrlichiomonas and Plesiomonas. That has probably been the biggest disadvantage, but they do, every now and then they will ask us, and we actually do ship out for that if they do ask us. But they didn't order it much before, and I don't think we've really had much of a problem since we've transferred over. I think there's so much, they're very pleased with how fast they're getting these results, so I don't think that they're that upset. But yeah, that was a drawback.
I have similar experience here. I haven't received too much pushback with respect to that. Oftentimes, if the molecular panels are negative, sometimes a culture will be ordered anyway. So from our standpoint over here, we've not received that much of a pushback.
Great, thank you both for weighing in on that. Our next question, maybe Dr. Lopansri, if you can actually address this one first, and then Dr. McNabb can also comment on this. So this question is, can you talk about the recent reimbursement changes and how it might affect your decision to use these panels in the future?
That's a great question. So this is sort of stuff that's hot off the press, and it's sort of emerging. And so we're trying to figure out what the landscape is going to look like going forward. I think, in general, I think use of these panels have certain value with different clinical scenarios. So I am not, while I understand the intent to control costs, as unmitigated use of these tests would pretty much can potentially escalate costs tremendously. I think there still are times when both tests are needed. I think what it will make us do is be a little more vigilant about how the tests are used. As I mentioned in my presentation, most of the pathogens that are encountered in the U.S. can be detected by some of the smaller panels, and so I think what it would prompt us to do would be to be more aggressive about policing how the tests are used, and being a little more aggressive about how to get about developing and pushing out clinical process models for clinicians to help guide use of these tests. We'd probably also have to consider using alternative means to get a handle on how the tests are used. So I think in short, this is something that's emerging, and it's something that we're taking seriously and taking into consideration seriously, and we're trying to strategize how to move forward if, in fact, it does go forward.
I agree wholeheartedly. It's the big issue here really has been some of these larger multiplex panels that come out. Our physician staff lean towards wanting to be able to do just parts of these panels if they're very large. And we're a community hospital, so we have a varied payer rate here. So our management team, when they look at these panels, they do get very concerned about getting reimbursed for a large panel. Now, with the panels that we currently run, all the panels we offer, we have not had any problems with getting reimbursed. And I've checked that the last 2 years, especially with the enteric panel, because that was a concern. But if we adopted larger panels and ran them and didn't offer some flexibility to our clinical staff, I think that there's going to be a risk there. And we do consider that when we get ready to adopt some new technology. So I think that is something to be considered when you're adopting these panels. Are you going to have flexibility in what markers are going to be reported? But I do think the key really is to get the physicians to utilize them correctly, and you're going to get far less pushback from reimbursement if they're providing good information.
Great, thanks very much for those answers. We have time for one more question today. So this audience member writes, I am interested in a molecular platform, but am getting pushback due to concerns on the part of some of our clinicians about false positives. Did any of your clinicians have similar concerns, and if so, how did you address them?
Oh, that's a great question, and as I alluded to in my presentation, that is something to be aware of. And so our clinicians they call. They don't hesitate to call when they see a positive for Yersinia. They're on the phone with us right away. And we also have a very active stewardship group, and they review a lot of these tests that come up positive. So you know, I think it is something to be concerned about, but I think when you weigh the just the effectiveness at more rapidly detecting these pathogens, you know, I think it balances itself out. But I think it's important for the clinicians to be aware that, you know, you got to look at this from the prism of pretest probability and the clinical likelihood of certain scenarios. So if you have someone who's has no epidemiologic exposure, look at the Vibrio with or a Yersinia with a degree of skepticism.
All right, great. Well, thanks to you both very much for those answers. We have now reached the end of the question and answer portion of this webinar. And if your question wasn't attended to during the Q&A session, the team from Luminex will do their best to follow up with you after today's webinar. Well, thank you very much to everyone for participating in today's conference. You will be receiving a follow-up email from XTalks with access to the recorded archive for this event. A survey window will be popping up on your screen, and your participation is appreciated as it will help us to improve our webinars. Now please join us in thanking our speakers, Dr. Lopansri and Dr. McNabb, by clicking the link that I've sent to all participants through that chat box. We hope you found this conference informative. Have a great day, everyone.